Hi, everyone. My name is Sarah Klein. I am the CEO of the Epilepsy Foundation of Colorado. It's great to see, well, I can't see you, but hopefully you can see me. But it's great to have so many of our friendly faces out there in the crowd. I think I know a lot of you, and I think there's some new friends out there as well. And I guess friends are just strangers you haven't met yet, right? So thanks so much to all of you for joining us this evening. This is our third annual Epilepsy Connect Symposium, and this week's symposium is presented by our friends at AZI. We're really grateful for their support. They're a great friend to the Epilepsy Foundation and to the community that we serve. So thank you to AZI for presenting this week's symposium. We're really glad you're here with us tonight. This is a great week of educational conference sessions on all things related to epilepsy. And we're really excited about tonight's session on epilepsy and health disparities. This is an issue of big concern to us at the foundation as we try to connect, educate, and empower everyone who is affected by epilepsy. Our speaker tonight is Dr. Ed Ma, but before we talk about him, I just want to give you a couple of logistical notes about this evening. So you might have noticed that the chat feature on the Zoom tonight is not enabled, but if you have questions, there's a little Q&A box at the bottom of your screen. So if you have any questions tonight, just pop those into the Q&A box, and we will be checking that throughout the evening, and we will make sure that there's time at the end of the session for us to answer any questions that you may have. So make sure you put those questions in the Q&A box, and we'll be sure to address any of those that you may have. And if for any reason that we don't have time to get to all of them tonight, we will be collecting all of those, and we'll be sure to get those addressed after the fact if we can't get to any of those tonight. Anyway, our speaker tonight, though, is Dr. Ed Ma, who is the chief of the Brooke Gordon Comprehensive Epilepsy Center at the Denver Health Medical Center. Try to say that without twisting your tongue. But Dr. Ma attended the Louisiana State University School of Medicine in New Orleans, and then completed his neurology residency and epilepsy fellowship here at the University of Colorado Health Sciences Center. He also serves as the assistant professor of neurology there. He is a passionate, motivated, and patient-oriented physician, and is respected and admired by both patients and colleagues alike. Dr. Ma has been recognized as a 5280 magazine top doctor every year since 2012. He has been on the board of the Epilepsy Foundation of Colorado longer than anyone remembers, and is also on our professional advisory board. Actually, I looked up to see when he started on our board, and I couldn't find it. It's longer than anyway, much longer than I've been at the Epilepsy Foundation, but it's been a long time. I think he's like one of our founding board members. Anyway, we are extremely grateful for his leadership, for his expertise, for his passion for the epilepsy community. And I think as you listen to him speak, you will see that that passion for people living with epilepsy is deep-rooted, and he is well-placed in his position at Denver Health to serve our community. So it is my pleasure to introduce Dr. Ed Ma. Dr. Ma, take it away.
All right. So yes, I was asked to speak about epilepsy and health disparities. And obviously in the time of COVID, these health disparities are front and center with what we've been sort of seeing throughout the country. And so epilepsy, unfortunately, is no different. And the statistics, when I started really looking and preparing for this talk, I apologize, will likely be very uncomfortable in their nature. But, you know, raise your hand, ask questions. I'll try to do my best to answer them. And if you have any good solutions at the end of this, that would be fantastic, because I think we're all looking for those. So today, I'll just very quickly run through definitions, some epidemiology, something called the facets, which is basically a mnemonic that we can use to think about healthcare disparities, and then how I chose to address this particular problem in Colorado many years ago. So the Centers for Disease Control defines a healthcare disparity as a preventable difference in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by a socially disadvantaged population. And who are those populations? Well, people of color, non-English speaking, low socioeconomic status, the LGBTQ community, undocumented folks, and the incarcerated, rural, children, elderly, and developmentally delayed. So if you look at all of these lists of people, it's probably a lot easier to think about them as sort of non-tax-paying white city dwellers, which I think sort of has been, as mentioned before, in the time of COVID, really brought front and center about how we're not really offering healthcare to all Americans. Well, epilepsy disproportionately affects non-white individuals. In 1990, that's my dog, sorry. The rate of epilepsy was 1.3 to 2.2 times greater for non-whites compared to white male individuals, and 1.4 to 1.7 times greater for non-whites compared to white women. Prevalence for African Americans is 6.7 per 1,000 compared to whites at 4.5 per 1,000. Elderly Hispanic men had prevalence rates of 15 to 18 per 1,000 compared to non-Hispanic men with 12 to 16 per 1,000. African American and Hispanic patients are less likely to undergo epilepsy surgery and more likely to be treated in emergency departments for their seizures, less likely to receive seizure drugs, and less likely to receive specialized epilepsy care compared to white folks. In the NIH study, which is where most of these statistics in this talk come from, by 2011, there were only 5 studies looking at this problem, healthcare disparities in epilepsy. 3 papers from the US, 2 from Canada. They only looked at 2,169 patients, and most of those patients were actually from Canada. So with regard to knowledge and attitudes, this is where it gets uncomfortable, so don't shoot the messenger. But people living in the southern United States and those with only grade school education were least informed about epilepsy. Parents who objected to their children having a friend with epilepsy declined. That's good, from 24% in 1949 to 5% in 1974, and 22% in 1947 compared to 81% in 1974 thought people with epilepsy shouldn't even work. So again, that's good that it's improving, but it's still a far cry from where we need to be. In 1947, 13% compared to 2% in 1974 thought epilepsy was a form of insanity. Men living in the South and with only grade school education had the most negative attitudes toward persons with epilepsy. And yet still in 2000, 30% believe epilepsy is a mental contagious disorder, and 41% thought it appropriate to place an object in a patient's mouth during a convulsion to prevent injury. So we still have a long way to go in terms of education. Some Native Americans attribute epilepsy to spiritual causes, and in Hispanics, 33% believe persons with epilepsy are more dangerous to other people. 8% thought seizures were caused by sins and that exorcism would be a good remedy. Workers are more worried to have a coworker with epilepsy than multiple sclerosis. Higher status employees, again, translated probably to higher education, had less discomfort related to epilepsy. With regard to compliance and seizure medication, it's probably not surprising, but more patients were found in the non-compliant group reporting financial distress, difficulty interacting with their physician, and having Medicaid as opposed to private insurance, and didn't have regular responsibilities. And these are all statistically significant. With regard to employment and education, lower income, higher unemployment rate, and lower educational attainment were seen in those with epilepsy compared to age-matched peers without epilepsy. Children with epilepsy have a decline in academic performance when they have recurrent seizures compared to those children with epilepsy but without seizure recurrence, suggesting that it's the epilepsy itself. These children also have poor social skills and are less assertive than their siblings without epilepsy. With regard to mental health care in children, prevalence of psychiatric diagnosis, comorbid psychiatric diagnosis was 61%, but only half received the mental health care they needed. Significantly more parents with no education in the group that did not receive mental health care. That's an awkward sentence, sorry. Parents with lower education basically didn't get their child looked at, is what I'm trying to say there. An absence of mental health care was associated with older age of the child, more than one psychiatric diagnosis, or being on multiple seizure drugs. With regard to healthcare utilization, persons with epilepsy had 10 to 25% higher use of family doctors, specialists, nurses, and psychologists and counselors. In other chronic diseases, the difference was also present, but much smaller, only 4 to 9%. Persons with epilepsy visited the emergency room, were admitted to hospital, and received telephone advice 8 to 10% more frequently than those with other chronic diseases. And there were obviously higher rates of hospitalization among women than men with epilepsy. There are also disparities in the rates of epilepsy surgery. And again, I was looking at the viewer list, and you probably don't have much questions about, epilepsy surgery as a therapeutic option. But if anyone does have questions as to why this is a very big and sad deal, let me know. We can talk about it. But in this study, African Americans compared to non-Hispanic whites had lower rates of epilepsy surgery, but by an odds ratio of 0.3%. They also had less if they were receiving Medicare and if they were from a lower socioeconomic status. This odds ratio was 6, but it wasn't statistically significant, but that showed that trend. With regard to outcome disparities, non-whites were more likely than whites to be non-compliant with medication as determined by drug levels. Lack of insurance was also associated with lack of compliance, which seems obvious. If you can't afford your meds, you can't take them. After surgery, seizure-free women were more likely to divorce than seizure-free men. This is an interesting finding, and we can talk about that too. Seizure-free men that were married were more likely to be employed, whereas seizure-free women after surgery who divorced were usually unemployed. African Americans were more likely than whites to have seizure recurrence after surgery, although this was not statistically significant. And a second study also confirmed that there was no outcome difference due to this factor alone. So the facets. The facets of health disparity was discussed and sort of written about by this group, Nathan and Gutierrez, in 2018. And they stand for fear of treatment, access to care, communication barriers, education, trust between patient and physician, and social support. With regard to fear, it's not been specifically studied in epilepsy, but African Americans score higher on fear and pain and anxiety scales before and after surgery, a knee surgery, compared to non-African American patients. In African American patients who needed a kidney transplant, they also reported greater feelings of guilt and fear, and as a result, typically did not ask for the transplant, even when they were eligible. And this is really sad. So with regard to access, temporal lobectomy rates for whites were about 6.5%, and non-whites much lower at 2.4 to 5.9%. Whites are more likely to have private insurance, which itself increases the odds of getting a temporal lobectomy. In one study, African Americans and Hispanics in New York and Houston had higher rates of generalist visits and lower rates of specialist visits. This also held true for low socioeconomic status, the uninsured, and Medicare, Medicaid folks. This relationship held when controlled for age, sex, seizure frequency, and comorbidities, verifying that the disease burden did not explain the differences in care. African Americans were more likely to have non-private insurance and have more visits within a calendar year compared with white patients. One study looking at over 100,000 patients with refractory seizures showed that 9% of African Americans and 24% of Hispanics had access to specialized health care, but this was compared to 57% of white patients. At the University of Alabama, they demonstrated that African American folks had a 60% decreased chance of undergoing surgery when all other factors were controlled. Fortunately, since the Affordable Care Act, an early study repeated looking in the range 2012 to 2013 showed no racial disparity in access to temporal lobectomy. And this is one of the important aspects of being able to offer insurance by any means to as many folks as possible. And if you've seen me on Facebook talk about those things, that's why. Communication, compared to English-speaking US-born patients, Spanish-speaking patients received lower numbers of seizure drugs even when age and duration of epilepsy and seizure frequency were taken into account. Patients with limited English proficiency who had mesial temporal sclerosis, which is the most curable form of epilepsy, were much less likely to undergo temporal lobectomy despite this issue. In a colorectal screening study, non-English speaking patients improved screening rates when a language concordant patient navigator was used. And that seems pretty obvious. And potentially one of the things we can do about these disparities locally. Poor physician communication skill can also lead to disparity, as observed in lower African American rates of temporal lobectomy, even when medically eligible. Post-visit survey data with audio tape analysis showed African American patients had shorter visits with white physicians, and physician verbal dominance was significantly higher in visits with African American patients than in visits with white patients. And this was seen in both African American and white doctors. So it was actually physician independent. With regard to education, persons with epilepsy had lower educational attainment in general and health status compared with healthy adults. They are less likely to complete secondary education or post-secondary education. African American patients had a greater mistrust for medications compared to white patients, despite similar education levels. Pharmacist-centered patient educational programs did improve patient beliefs about their medications. And one survey looking at Spanish-speaking adults in the US found that 8% believe sins are a cause of the seizure, and that 10% agree that exorcism is a viable remedy to epilepsy. Fortunately, I can say at Denver Health, in the 15 years I've been there, I've only seen exorcism attempted 3 times that I'm aware of. And I was only aware of it because they came back and followed up and told me they did this. Trust. As mentioned above, poor physician communication skills can also lead to disparity, as observed in lower African American rates of temporal lobectomy when medically eligible. And again, sort of reiterating that previous fact, UAB demonstrated that African Americans had a 60% decreased chance of undergoing epilepsy surgery when all factors were controlled. And there's obviously great mistrust of medications compared to white patients and African American folks. And a lot of this has to do with, our history as the medical establishment and, what we did to our Tuskegee Airmen in the syphilis trials. Meaning we let them have it and didn't treat them to see what would happen, if any of you were unaware of that. With regard to social support, having epilepsy is associated with lower incomes, higher unemployment, and lower educational attainment. Lower socioeconomic status is associated with lower medication compliance, higher psychosocial distress scores, and lower self-perceived health. Home ownership is associated with a decreased risk of epilepsy. And married patients are more likely than unmarried patients to undergo surgical treatments of epilepsy. Hispanic patients have less health insurance coverage, receive less seizure medications, had higher depression scores, and receive less antidepressant medications compared to white counterparts. And decreased quality of life in Hispanic patients may also be associated with negative stigmatization about epilepsy within the culture, i.e. this idea that it's punishment of God and needs to be exorcised. Physician bias. This is obviously very uncomfortable for a physician to say and admit, but I've seen it. You've all seen it, but not specifically studied in epilepsy, fortunately or unfortunately. In a study about coronary angiograms, physicians rated African American patients less intelligent, less educated, and less compliant with medications compared to their white patients. And in an online study, these same physicians were presented with clinical vignettes of patients of various races presenting to the emergency room with chest pain. Results showed that physicians thought African American patients were less cooperative with medical procedures, and ultimately led to more hypothetical white patients being treated with thrombolysis compared with African American patients. Basically, because of this preconceived notion of African American patients being less cooperative, they did not receive standard of care therapy, life-saving standard of care therapy, in as high rates as their white counterparts. So, possible interventions. You really can't fix a problem if you don't know that something is wrong. And then you can't fix that problem if you don't know what is wrong. So these are some ideas. So we can measure the facets. So with regard to fear, in our visits, we can start to incorporate pain and anxiety scales during clinical consultation. Possible interventions to address patient fear is to use support groups, patient testimonials, and honestly, we probably all need this in medical school and beyond, MD cultural communication training. Access, we can measure the percent of surgeries, epilepsy surgeries in minority groups referred for brain surgery versus whites referred with the same kind of insurance. And as a possible intervention, we can hire social workers, use telemedicine to engage patients where they are in their homes, and MD bias training again. With regard to communication, we can measure use of and success of live interpreter versus phone interpreter. We all know which is better, and we can sort of measure this and then prove it to the people who need to see this so they can sort of allow us to use more financial resources to address this issue. We could also measure MD time and interaction with minority patients. That was a shocking statistic that I had read in preparing for this talk, and absolutely, it's a good idea. To intervene in this particular realm, again, MD bias training is a good idea, as well as cultural competency. We can also use scribes, so the MD can have more face-to-face communication rather than the patient to the back of the MD head while he's typing or she's typing. It's also helpful to have these issues made aware in hiring decisions. When MD to patient racial concordance is high, trust is better, communication is better, everything is just better. But even in Denver Health, where I work, the vast majority of patients we treat are non-white, and yet the vast majority of physicians are still white. We can all do a better job at sort of looking for a broader variety of qualified candidates. With regard to education, we can test the level of understanding of a procedure and outcome at the conclusion of the clinical visit. We often sort of think we're doing a good job and then sort of find out later that the patient had no understanding of what we were discussing. Either we were talking over their head, we were talking too quickly, as I'm doing right now, or whatever factor happens in the clinical visit, asking the person at the end of the visit, what did you understand about that? What did you think about the outcome? These are all really good ideas and easy to do. Additional interventions for that would include visual aids and handouts in the target language. With regard to trust, we can test for pre and post-visit distrust scales. That's super interesting. I had never thought about that, but I think it's a good idea. And as a possible intervention, we can incorporate patient testimonial, community engagement, and education about epilepsy and epilepsy therapies. And social support. We can evaluate post-surgical or after clinic social resources for each patient. We have at Denver Health a social worker who is embedded within the clinic, and so we're able to do this. Many of my colleagues who practice in epilepsy, I don't think have that degree of support, and it's been very helpful. But with regard to intervention, post-procedure follow-up, social worker, community contact, patient advocate sort of phone calls can go a long way to helping people navigate, the post-clinic world. Pharmacist follow-ups, again, demonstrating that, a pharmacist-driven conversation about medication can increase trust levels about the medications. This is a huge idea, again, for a hospital system to purchase a pharmacist just for this reason. You can imagine it's not a cheap endeavor. So it makes sense that that's not widely available. And so, I suspect I was, probably asked to provide this lecture because in 2007, I started the first epilepsy program at Denver Health. I was nearing the end of my fellowship at the time, recognized a tremendous need right across the street when the university was still at 9th in Colorado, and partnered with the Daniel School of Business to put together a business plan and pitched to the CEO to hire me to start that program. It is a integrated health safety net. We are a level 1 trauma center. We run the paramedic system. We have multiple family clinics, school-based clinics, public health department, poison control. We also have the adult and adolescent psych unit. We have a nurse line, detox center, and correctional care medical facilities, one of 3 in the country. And our old motto used to be level 1 care for all. I still like it better than our current one because it's true. We see 1 in 3 adults in Denver County and 2 in 5 kids. And we are really aimed and do, I think, a particularly good job at a lot of these underserved folks, poor, uninsured, undocumented, mental illness, incarcerated, persons with addiction, homelessness, and HIV/AIDS. So in 2012, in preparation for a study I was doing, trying to understand my patients' use of cannabis. Again, this is unrelated to this talk, but this was part of that study. I did an anonymous survey from September to December of 2011 and captured 120 of 178 unique patients continuously. So I had 128 respondents. 56% were men, average age of 39, 44% were women, average age also 39. And this is the racial breakdown. So again, whites and Hispanics were almost about 40%. Black or African American, almost 20%. American Indian and Native, a little less than 3%. And me in the clinic, that's other, just kidding. So with regard to seizure control, my patients are highly refractory. Only 17% were reporting total seizure freedom. Again, this is in a anonymous survey, so I'm not entirely certain of the truth of it, but everyone was under the same conditions. 68% of my folks were using 2 or more seizure medications. And you can see these graphs from the original study. 79% of my folks basically had less than a college degree. Some high school, some college degree, trade school, professional degree. Very few people were at this end of things for my patient population. And 77% were unemployed, disabled, or retired. Again, a really challenging patient population. 80%, and this was the shocking thing to me, and why I realized Denver Health intuitively at the time was really the place for me to sort of make an impact. Because at the university, I saw lots of folks who were really devastated, but they were, fortunately, had supportive parents, had supportive spouse. But at Denver Health, 80% were single, separated, or divorced. It was shocking. And this is also equally shocking if you can think about living in Denver, even in 2011. 79% were making less than $15,000 a year, with a single poverty line at a little under $12,000 a year. And so this is what we look like today in 2020. We're a level 4 epilepsy center. We have adult and pediatric epilepsy clinics. We do adult and pediatric epilepsy monitoring. We're able to do adult phase 2 monitoring with subdural and stereotactic EEG. We do neuropsychological testing, water testing, and brain surgery. We have resective brain surgeries, minimally invasive stereotactic surgery with ROSA, laser-induced interstitial thermal therapy with Visualase, and we implant neuromodulatory devices, VNS, RNS, and we're capable of doing DBS, although we haven't actually done one yet. And we also have a weekly referral network epilepsy conference and surgical case discussion. And so we're really trying to, bring modern care to folks that historically never really had it. Okay, and that's the end of my talk. And I open this to questions, especially since, again, a lot of the numbers are very sad. Let's see, should I stop sharing?
No, I think you can leave your leave your slide up there. That's fine. And I'll join you on the video. We don't have any questions yet in the Q&A box. So if anyone has questions, please type them in so that we can be sure to answer them. But I've got a question just off the top of my head. And first of all, thank you. That was A little depressing, yes, but it's really informative. And I mean, I think just based on the number of the people that are on this call, it's clearly, a subject that's of great interest and concern to a lot of people. Obviously, this is something that we at the Epilepsy Foundation are, you know, interested in addressing as well. Is how do we sort of flatten those numbers so that people have better access and better information. One of the things that struck me was when you were talking about providers especially, but is the idea of cultural competency. And it sounds like that's something that is maybe provided as training for the healthcare providers at Denver Health. But how would, from your experience or from maybe the training that you've taken, how is that provided? What is, how would you suggest someone increase their cultural competency when dealing with, with a diverse patient population?
That's a fantastic question. The short answer is I have no idea. Secondly, it's not part of the medical education that I received. But, I think just the secret to being a good doc to your patient is just to listen, and so when patients are sort of telling you seemingly crazy things, check your own background at the door, write it down, absorb it, and if you don't understand it, ask questions. I don't have a good answer. I mean, I think these are courses that probably need to be developed. I think these are opportunities to do better. I would say that paper that I sort of completely ripped off for this talk was not that long ago, and the conclusion is more research is needed. And so it's really sad. We're no better than it sounds like at the start. However, I would tell you one thing. When I was sort of putting this all together, let me go back. This mouse is slow. It's probably not very PC. I would tell you it's not PC. But when I made this slide, and I looked at this list and I said, that's basically everybody who's not this. The answer to me is that this is institutional racism. That's the answer. How do you defeat it? Well, those are the hard questions that I think we as a country need to have, aren't ready to have. But I think this election, may force the issue. I don't know. I'm not entirely clear. But these are much bigger issues than just epilepsy. Wah, wah.
So we do have some questions that have come in now through the Q&A. So I'll just kind of start at the top. So do you know any information or statistics on disparities by state, like how Colorado compares to other states, Alabama, the South?
That's a great question. I don't have any specific studies. Again, this NIH study sort of underlined, this particular issue. I would suspect that Colorado probably does a fair job by comparison to other parts of the country. I would tell you that in my personal experience, it's not all of Colorado. I would say it's in, in the Denver metro area, the I-25 corridor, the areas of wealth accumulation, we do better. And even in the rural areas, the Western Slope, they're not doing as well. And I think it has to do with some of these issues that we talked about.
Since you have the NIH study slide up in front of you, I'm going to skip down one question. So with the NIH study, this looks like the date of the study was in the 70s. Is there any more recent data? Anything from anything from 2020 or anything more recent than 1974?
That's a great question. I don't know. I have to admit, I found a really good paper, and I did not sort of continue to dig and dig and dig in the reference section because it sort of hammered the point. I suspect, compared to 1974, 40 plus years later, we're doing a lot better than even this, because in terms of the arc of justice, or whatever the statement is. I think we know better, so we do better, and it just takes a long time.
Yeah. How much time should a doctor spend with a patient to have great communication and establish trust?
Oh God, I would love the old days when I had an hour and a half to talk with a patient, and then I can go talk to Dr. Spitz after I sort of, because I was one of many residents, and he was sort of staffing a bunch of folks, and I could just sit and just listen. Now that I'm on the other side of things as an attending, and I'm trying to manage 3 and 4 residents coming to bring me information about patients, it's not as easy. I think face-to-face visits, when you look at on the money side of things from the hospital administration, they want you to see people every 15 to 30 minutes. I don't think that's enough time, unless you already know the person, and so there's not a great scenario right now that I can see, even in my own hospital. I'll readily admit we're moving in the direction that everyone else has been moving to. I think the folks who are sort of bucking the trend and sort of creating this, concierge idea, are still trying to hang on to the old days, when you might bring a pie and a chicken to see your doctor, but he spent all afternoon with you, it's somewhere in between. Yeah, and it depends on the person. It depends how long you've known them. I mean, I've been at Denver Health now between residency, fellowship, and now faculty since 2002. So, a lot of my folks, they know me. They ask about my kids, I ask about theirs. And so a 5-minute, really focused catch-up visit is actually a lot more meaningful than, typing out every single sort of thing that I would need to do with a first visit. And so I think it really depends. But yeah, I think for the modern era, I think if you can get a 45-minute visit, you're doing pretty good.
Dr. Ma, do you only take care of people in the Denver area?
I currently only have clinics at Denver Health, but I would tell you one of the interesting things about COVID is that we're never going back to not using telemedicine again. And so I think, especially the Western slope, I think people with epilepsy, i.e. all my patients, telemedicine is fantastic. Because I'm not having to sort of beg them to find a ride that could fall through at any minute because, my mom is working, she can't bring me in. And I don't want to take, 4 buses and sort of miss it by 20 minutes because then they turn me back and I got to go back. These things happen. I think, telemedicine will sort of really allow us to address people where they're at. And I think that's a good thing. And so to answer your question, I don't currently, but I can. And I would tell you, I have a couple of folks from Basalt, who still come down because they like to come to Denver to shop. But, if I make a medication adjustment and I want to know how they're doing in 3 weeks, I'm not going to make them turn back around. I'll just have them, either drop me an email or, we could probably even do a televisit.
Is epilepsy surgery very common? And what kinds of epilepsy would benefit from surgery?
Yeah, so epilepsy surgery is not as common as it should be. Epilepsy surgery potentially is curative for epilepsy. And that's sort of when somebody finishes a neurology residency and they really fall in love with epilepsy as a care state that they want to focus on. It's usually the epilepsy surgery piece of it because it's so impactful when you can pull it off. Now, the problem is the vast majority of epilepsy patients probably aren't, fantastic surgical candidates, but when you find them, it can be really exciting. and empowering and life-changing. Taking somebody, afraid to come out of their parents' basement to walk the dog because every time they have a seizure outside, they lose the dog, to making them, a tax-paying citizen. It's, but the perfect surgical candidate, in the old days would be somebody who's got a lesion, somebody who's got something on their brain MRI that doesn't quite look right, and that we can prove through a variety of tests that I can talk about now or another time, to prove that the seizures are coming from that spot, and to also prove that that spot doesn't really do anything for you other than seize for you. And if you can satisfy all those things, then you can remove it and have a really good shot at stopping their seizures. Now, that's, again, you could imagine that's not a lot of folks, but there are enough to kind of keep us, fighting and going. And that was the old days. I would say with the advent of stereotactic EEG, minimally invasive surgeries, visual ACE, robotic sort of placement of intracranial EEG, we're able to offer, neuromodulation opportunities where I don't think we would have before. And so between VNS, RNS, and DBS, you can treat many more folks, quote, surgically, that aren't really resective candidates, which is why I had that list of all the sort of more aggressive non-medication options. Yeah, I mean, it's an individual response, it's a blanket answer for a very individual response. Yeah, and I'd be happy to whoever asked the question, sort of, have more a detailed conversation offline.
There's a question in the Q&A about the Epilepsy Foundation, but before I ask or answer that one, I'm going to ask two other questions about different types of disparities. One is about sort of geographic disparities. So what can you say about, I guess, more access to care disparities? So you've mentioned a couple of times, like the western slope of Colorado.
Yeah.
What do you see, I guess, from your experience? I mean, Denver Health is obviously a central sort of urban healthcare center where, you've talked about your patient population is very much the kind of the Denver centric. Yeah. But what's your experience in terms of just like access to care and those disparities in terms of, people in the rural areas and, lack of access to even, whether it's primary care or neurologists or epileptologists? What's your experience there?
Yeah, I mean, it's a big problem. And I think it sort of gets buried under all these, more sexy topics of, racial inequalities, socioeconomic inequalities, LGBTQ, issues. Folks out in the hinterlands are, have epilepsy just as often, and the resources are far worse. I mean, mass transit is almost non-existent out there. And, subspecialty care is very, very challenging to get, even for the Western Slope, the specialists out there are in the big cities, the relatively bigger cities like, Basalt. But, and Dr. Collier is doing wonderful work in Grand Junction. I mean, she's the only subspecialist out there, on the other side of the Continental Divide. I believe she's the only epileptologist serving that the upper quadrant of the state. Because, to get even a neurologist out there is a challenge, let alone a subspecialty trained epileptologist. It's a very challenging thing. And yeah, it's not great. On the flip side, the Epilepsy Foundation has done wonderful things to make inroads out there. They have representatives out there. And as I mentioned before with telemedicine, I think this is going to change everything. They'll be able to, with family practice, internal medicine, even general neurology, be able to sort of, over time, have access to subspecialty care. And let's be honest, why haven't we had it before now? Because no one got paid for it.
Yeah.
I mean, that's the ugly truth, right?
Right.
And now that because of COVID, we get, I think 30 or 40% of whatever it is a typical visit is. Now people are fine doing it. It's just like, and why weren't you fine before?
Yeah, that's definitely one of the silver linings of COVID, right? Is
absolutely
reimbursements for telemedicine.
Yeah, but But I think it's so widely popular. I don't think that's going to go away. It might not be 40%, it might not be 60% or whatever it is. I don't actually keep up with that stuff. But it's not going to be zero, and I think it'll be worthwhile, especially in really tough populations, to be able to offer that.
Is there access to the Epilepsy Foundation in Grand Junction? So we do have a ambassador in Grand Junction who is basically a kind of a high-level volunteer out there. I will tell you, we are planning our first ever walk in Grand Junction next summer. So we will have a walk out there in the summer. We are definitely trying to grow our presence out there and put on more programs and offer more services. So that is definitely a priority of ours, is to extend our reach out into the kind of greater Colorado communities. So that's a big priority of ours. So yes, is the answer, is that you can access us. And honestly, like, this is one of the silver linings for us as an organization too. I would just say, kind of in conjunction with what you just said, Ed, is we're offering more of our programs and services virtually. And it's kind of the same question. Why haven't we been doing this before, right? Like, the last 2 years, this symposium has been in person, in one place, on one day. Right. And if you didn't happen to live in Denver, I'm sorry. Well, we recorded it, so you could, if you happen to know our YouTube page, you could definitely find it. Yeah. But it limited who could attend, and shame on us, right, for not doing that in the past, because it created barriers and obstacles, and of all organizations, we should be the one who is making an effort to be more inclusive and to reducing barriers, right? And so again, we will never not do our programs virtually ever again, right? Even when we're able to return to in-person events, we will always have a virtual option, because it's the way that we can invite and include and welcome an infinite number of people, which is our goal for everything, right? So that's definitely a big learning and a silver lining for us as well, is that we can be as expansive and as welcoming as possible.
And not to be too hard on ourselves. I mean, it's called a blind spot for a reason. I mean, you can't know what you don't see. Just like you can't fix what you can't measure. It was just like not the way things were done. And so now our eyes are wide open to this opportunity. I think anyone who sort of now goes back, shame on them. But I mean, our eyes are wide open now. Right. This was a viable communication line, and I don't see it ever going away.
Right. So the other question that's up here is, how does the Epilepsy Foundation conduct outreach to minorities, as many that attend our programs, walk, scale, et cetera, are white, and generate interest in minorities joining our board and other programs? Great question. You're right. A lot of the work that we're doing and a lot of the events and things that we do, a lot of our staff and board members are white, and that has been a new priority of ours. We actually have a new Hispanic outreach program that has been in the works for the last year or so, which is a new strategy of ours to engage the Spanish-speaking community in Colorado. We have a Spanish-speaking staff member now, which is new, but it has been something that's been lacking in our organization over the years. And, again, that's something that we want to correct and something that we want to address. And we definitely want to be more inclusive and engaging and proactive about being a part of the solution to, the disparities that Ed has just been talking about. So we do want a more diverse board and a more diverse community and who's participating in all of our events and all of our programs. That's something that's really important to me, and I think to our board and to all of our staff. So and we welcome suggestions and participation in that process from all of our community. Thanks, Mark. And thanks, Eve, for celebrating with us in our virtual programming as well. We have time for a couple more questions. If anyone else has anything that they'd like to ask Ed, Dr. Ma? If not, I will say,
oh, I see one.
One more.
I can't.
Dr. Collier is so busy in Grand Junction. Well, yeah, I mean, as Dr. Moss said, she's literally the only epileptologist in the entire Western Slope, which is, as I can imagine, extremely just overwhelming.
I mean, speaking of, I'm super stoked that Dr. Doshi is down in Pueblo. For the longest time, we didn't have an epileptologist down there either. And
Yeah,
so the only quadrant we're missing now is Durango.
right. We need to recruit someone down there.
Yeah.
How is COVID affecting tests and appointments at Denver Health?
Dramatically. And just this week, we're sort of, curtailing elective procedures, which unfortunately we are one. I mean, one of the things at the very beginning, if there are any parents or patients out there, EEGs, we used to, have kids or adults hyperventilate. We haven't done that at all. That's considered an aerosolizing procedure. So we haven't done a single EEG since April, in which we ask people to hyperventilate. But what I would say is this: if you're coming in for a procedure, EMU phase 2 or whatever, we're having people get a COVID test 48 to 72 hours before presentation. And it's got to be clean, negative, and then the admission will go through. We have had a couple people have to postpone and reschedule because the positive test prevented us from allowing to do that. With regard to PPE, all of our technologists are fully gowned and gloved and masked. And eye shielded, and the patient is also asked to keep a mask on for most of the study as well. And so it's affected in those ways. But in terms of just sheer volume and numbers, we've really had to cut back a lot. The universities, I think, cut back recently. I'm not sure about Swedish. I suspect if they haven't, that's probably coming soon. During the early part, we all shut down completely. We did 0 cases for about 6 weeks, and it was horrible. So we have a tremendous backlog from the first part of this year. Since July, we've been sort of doing cases and trying to get in as many as possible because we were sort of gearing up for a second wave, which is pretty much now here. And so it's getting cut back again, to be honest.
One more question, kind of in the disparities topic. Do you find that children are listed on this slide that's up on the screen because their parents fall into the other categories? Or are there other reasons that you consider children to be disadvantaged based on age alone?
That's a really good question. As somebody who doesn't really treat kids, I'm only guessing at you. But I would think, children, because of all of these things, not that they're non-English speaking, but they might be non-English speaking, but, they don't always have, an independent voice. And so in a sense, their parents are their representative, literally and figuratively. And so everything's filtered. And so if the parent is any one of these other things, then that will trickle down to the child too. But I think in and of themselves, they probably are, slightly disadvantaged. Take for instance, medications. When something comes out, it's another year or two before kids can, FDA approved, you get it FDA approved to use, because they're not a target from the get-go. And why is that? Well, it's harder to do studies on them because you have to have permission, and it's just much easier and faster to ram a bunch of adults through a study. I mean, this COVID vaccine that's coming out, I don't think any kids got it. I could be wrong, but I suspect those are probably 40,000 adults and 30,000 adults in those 2 studies, and no kids. And so, by definition of being a kid, you're a second-class citizen, right? So, I mean, just look at this line. It's sad. Sorry to end on that note. You have another question?
Well, we have a comment. Someone who is a big fan of Dr. Spitz, who also says that you seem like the same kind of caring physician, which I think is true.
Well, thank you. Is that Chloe?
It's not.
It's not. Okay. I saw her on the list.
Well, it looks like we're about out of time. So I do want to thank all of you attendees. Thank you for your great questions. This was terrific. And I want to thank ASI again for being our amazing sponsor this week. But ultimately, I mean, really, thank you, Dr. Ma, for a very informative, very interesting presentation tonight. I learned a lot, even though it's
So sad.
kind of depressing. It is really, I do feel like, honestly, we have got this great group of people who are interested in doing something about this, I feel, right? Like it's not just we're here to learn, but we're here to make a difference. So I appreciate you. Yeah.
I think we're all here for that reason, and we have homework and a lot of it.
Absolutely. Absolutely. So thank you, Dr. Ma. Thanks for your great work. Thanks to all of you for being here tonight. We really appreciate your support of the Epilepsy Foundation and our community. Thanks for your time this evening. And we hope to see you at another symposium soon. You can come tomorrow night. We've got one more night of this conference this week. And we hope to see you again. Thank you again, Dr. Ma. And thank you all. Have a great night.